Welcome to the Advantage Workshop with Dr. Peter Nichol, a nationally respected pediatric surgeon and thought leader of surgical innovation and system optimization. With over 2 decades in the OR, including the past 17 years at the American Family Children's Hospital at the University of Wisconsin-Madison, Dr. Nichol brings clinical experience and research focus on human-based informatics, OR waste reduction, human error, and serial processing. In this Advantage workshop, Dr. Nichol will explore how emerging technologies are reshaping healthcare, identifying who will lead, who will fall behind, and what your team can do to stay ahead. Here is your opportunity to gain expert insight into the future of surgical services and what it takes to thrive in a tech-driven era. Don't forget to follow, leave a comment, and share this episode with your colleagues. Dr. Peter Nichol, thank you for joining us today, and you have the floor.
Thank you, Monique. So I'm Peter Nichol. I am a pediatric surgeon, and I'm going to be talking to you about what I see as the imminent collapse of healthcare that is happening even now as we speak. I like to show this picture. It's a photograph of Kilimanjaro about 2 days before we climbed it. And you can see what the destination is, but because the entire mountain is shrouded in clouds, you can't see the pathway. And I think this is a great metaphor for where we are in healthcare. I'm going to talk about how we got and where we're at. And I think what is going to happen next, how quickly that's going to happen, and who the winners and losers are. They're going to be sorted out through this. So I've been a pediatric surgeon now for 20 years. I came out of this training in 2005. I'm the Director of Surgical Services at the American Family Children's Hospital for the last 8 years. I'm a frustrated engineer. And I fell into sterile processing really almost by accident about 2 years after assuming the position of director of the OR, when one of my orthopedic surgeons was having repeated problems with bioburden, and I made my way down into sterile processing to understand that space, to understand why we're having problems, and opened up a whole world for me around human error and how that affects efficiencies, waste, and human performance. I have no financial relationships with any. I'm not going to discuss any companies. I have no financial relationships with anybody for the purposes of this talk. I will state that the views expressed here on social media formats, podcasts, and print outlets are my own. These views are informed by a robust and current understanding of the peer-reviewed literature that I review frequently. Also, analysis of government databases such as the Bureau of Labor Statistics, which is going to be disappearing here, I think, in the next 6 months. And my own peer-reviewed research and publications, and my experiences of working in 15 different healthcare systems, as well as data I've looked at from over 215 different healthcare facilities. These views are not a commentary on any specific healthcare system or facility and should not be viewed as such, but they are a general view on where healthcare stands today. So the coming collapse of healthcare. This was going to happen, has been in motion very slowly, much slower than this, for some period of time. So to understand this, you have to first look at our population pyramids. And this is a series of population pyramids. This is the United Republic of Tanzania. This is the United States. This is Germany. You'll know these two are somewhat similar, although we have a little bit broader base down here than Germany because we had a significant post-war boom with baby boomers and then subsequent generations. Germany was a country that industrialized fairly quickly, even though they went through 2 world wars. And when countries industrialize and people move out of rural populations into urban settings, they stop having children. And on the other side, you have Tanzania, which is a largely rural country, agrarian, developing country. And you can see they have many, many more people on the bottom, young people, than they do at the top, whereas Germany is becoming very top heavy. This is data from 2020, so this data is already outdated by about 5 years. But you see the subsequent generations that are coming up behind them are smaller than the largest generation there, which is the equivalent of our baby boomers. And our baby boomers are our largest population ever, followed closely by the Gen Ys. And I'm a Gen X, so I'm stuck in between there. And as the baby boomers age out, several things happen. One is as they turn 66, they retire. And as they get older, they require more healthcare. So this is some data from the 2019 study looking at healthcare expenditure by age, and you can see the group that consumes the largest amount of healthcare are people over the age of 65, followed closely by people between 55 and 64. And then it decreases by age as you go down in age. Now, if I superimpose the spending by age on our population pyramid in the United States, you end up with an inverted pyramid, and this is going to get worse. Your top layers are going to actually get wider because baby boomers are going to require cataract surgeries, orthopedic surgeries, heart surgeries, cancer surgeries. They're going to get hospitalized. They have all their well patient checks they have to go through, and the amount of work is going to explode. Meanwhile, if you look at our population curve, there are fewer people in Gen X in general, and there are several areas where we have significant shortages. One, for example, is anesthesia, and that's not just driven by our demographics, but that's driven by the fact that in the mid-90s, there was a report that came out that said we didn't need anesthesiologists. So for about 3 or 4 years, nobody was going into anesthesia residencies. We're now experiencing major shortages in nursing, dentistry. We're starting to see shortages in physicians. We have shortages in CRNAs. We have shortages in surgical technicians, and we have shortages in sterile processing technicians. There's currently about 63,000 sterile processing technicians in the United States. The unemployment rate for that group of people is 0.8%. It's very, very low. Basically, anybody who wants a job in sterile processing can get a job. But here we are in this environment where the amount of work, and particularly the amount of surgical work, is going to explode. So we will see a surge in procedures, hospitalizations, patient visits, work, charting, and all this is occurring in the midst of a nursing shortage, a shortage in surgical technicians, sterile processing technicians, physicians, dentists, the works. Now, there's some other issues around this when we start looking at this work and who's paying for it and how we're executing it that are going to be problematic. So in the United States, the vast majority of hospitals are not-for-profit, 58%. 24% are for-profit hospitals, and the remainder are government-run hospitals. So I don't know what you know about not-for-profits, but essentially, I've run a couple of these. It's hard to raise money. Hospitals are run as businesses, and they generate margins, but they don't have the ability, as public companies do, to issue stock and make long-term investments in technologies. So, for example, 20 years ago, if you remember, Amazon was a very hot stock, still is a hot stock. At that point, Amazon was losing money every year, but they're having no problem raising funds and selling stock because their future revenues look so good that people just kept investing. And now, of course, they're, I think, one of the Magnificent Seven. When you have a nonprofit or not-for-profit, you can't sell stock to raise money. And this becomes a real problem when you are facing significant problems around inefficiencies. And one of the things that's starting to happen now is that we have an entire healthcare system that's built around human tasking. And we're having fewer human beings available to do the tasks, and there's actually more work. And as you have more work, you end up with more stress on the humans, and their error rate starts to go up. So your inefficiencies start going up, your efficiencies and your margins start to tank. Okay, so going from here, so essentially you have a large group of hospitals that don't have the ability to raise money to potentially bring in technologies that could alleviate some of these problems. And if you think privately held entities like ambulatory surgery centers are going to be in a better position. They're not, because they also can't raise stock unless they're publicly traded companies. They can't raise money to fix their internal problems around errors and inefficiencies. Of note, the median margin for not-for-profit hospitals on average in 2024 was 1.2%. So they're barely treading water. And about 40% of them last year had a negative margin, 40% of all not-for-profit hospitals. And in 22% of those, the negative margin was less than 5%, less than minus 5%. So more than 5% loss on their revenues. And the median days of cash on hand for these not-for-profits is 196 days, 197 days. The last time it was that low was in 2014. This is only going to get worse as we look at these demographic pyramids, because the amount of work is exploding and the number of laborers is going down to do this work. The other thing that happens is that when people retire, they typically move out of private insurance into Medicare Plus, which reimburses at a lower rate. Now, Medicare and Medicaid are really important components of the overall national healthcare expenditure. And we are already seeing problems with policy coming out of Washington, D.C. in the last several months that these entitlements, Medicare and Medicaid, are going to get cut. And although they don't reimburse as well as private insurance, they're a necessary lifeline for these not-for-profits to be able to sustain themselves. So 21% of the national healthcare spend comes from Medicare. The crazy thing about Medicare as an entitlement is essentially almost all of it is borrowed, and almost 80% of it is spent on people over the age of 66. 18% of national healthcare spend comes from Medicaid. About 20% of that is spent on people, or 22% is spent on people over the age of 66. But as recently as last Thursday, Speaker Johnson passed a budget resolution in the House of Representatives that wants to put a work requirement on able-bodied people receiving Medicaid. That's about half the population's on Medicaid, which means, in essence, you're going to potentially throw half the people who are on Medicaid off Medicaid and cut that spending in half. Ironically, Medicaid is the one entitlement that we pay for in entirety. We don't borrow money to pay for. But if you do this across the board, on average, you're going to reduce the total national healthcare spend by 9%. And when you consider that only, 60% or so of the not-for-profits last year were able to make a positive margin, on average about 1.2%. If you take away 9% of their revenue, they're all going to be in the red, all of them. And so here we sit. This is how we've gotten here. And it started, this was going to happen anyways as the baby boomers aged out, but now it's going to accelerate. The other thing you need to know about population pyramids, at least in developed countries, is that the majority of the investment spending happens, is done by people largely between the ages of about 45 and 65, because they've purchased their houses and paid that off. The kids are all out of the house and off to college, or they're done with college, and you have these sort of golden years where you have dual income, no children, and you're not retired yet, so you still have an income stream. So you are putting all your money into the markets, investing in capital. As the baby boomers retire, all that money is going to go into treasuries and into savings accounts and CDs. That kind of money does not get invested into new technologies. It doesn't go into the stock market or into startups. So while all this is going on, the amount of money and capital available for innovation for the technologies we're going to need is also being constricted. Oh, and just so you know, we have this whole Doge thing going on. 46% of the federal budget is entitlements, and the vast majority of that we're borrowing money for. So although I appreciate efforts to govern efficiency, the bottom line is that is really just a a grain of sand in a much larger sandbox of problems here. So as I see it, the solutions for this, it's pretty simple. You have fewer workers, you have more work, and when you have more work, you have more stress. Human beings are prone to error, and the rates of error for specific tasks go up as the complexity of the environment increases and as the stress increases. So you can imagine what is going to happen is we're seeing more and more errors, and these will translate into losses in efficiency that are already, efficiencies that are already not that great, monetary losses, greater rates of medical error, overall the system moving towards entropy because we cannot continue to task just with human beings to fix all this stuff. And so really this is what healthcare looks like to me today, is that we're putting all this together with human tasking, and we need to start coming up or applying solutions that won't remove the human, but will elevate the human and reduce the rates of human error. So this is a drawing from one of Dr. Seuss's books, How Lucky You Are, about people working on the Bungle Bung Bridge, which I think is an apt metaphor, at least visually, for where we are today in healthcare. So this is really where we need to go. Things need to be finely tuned, finely machined, like manufacturing. But healthcare is a very, very complex system. It's not like high-end manufacturing. It's vastly more complex than that. It has many more variables involved, and one of those variables is human behavior. The other is the human condition of disease. So with all this, as we move through healthcare transformation, the collapse, and eventually the reconstruction of it, there are going to be winners and there are going to be losers. And I would say right off the top, the first winner, just looking at supply and demand here, is going to be labor and potentially labor unions. I say potentially labor unions because labor unions are going to have to adapt to the evolving environment. There's going to be such an acute shortage of laborers in healthcare that salaries are going to go up dramatically. The cost of labor is going to go up dramatically. We cannot do healthcare without humans. But if labor unions don't work to make cooperatively with other stakeholders to make the work environment better, they will not be relevant. What do I mean by that? I mean, they need to walk hand in hand with a number of the industries here who are also going to be some of the winners to make the work environment safer, better, reduce the rate of human errors, reduce the burden of work on the laborer, on healthcare workers. So we reduce the burnout and the expenses we are paying in terms of our mental wellness. So labor financially is going to do very well. Labor unions are going to have to adapt. Nonprofits that become for-profits. So there are a number of these throughout the country. Kaiser Permanente comes to mind. The Mayo Clinic, the Cleveland Clinic, both are sitting on enormous portfolios of cash and real estate. I think Prime Health, which is based out of Ontario but owns a bunch of hospitals in the United States, is actually a for-profit. HCA is another one. These are very large healthcare organizations that have significant resources that can start purchasing healthcare systems in other states, and essentially will probably undergo some sort of merger acquisition period, kind of like with the airlines. We're going to get down to 3 or 4, maybe 5 major not-for-profits that become for-profits that have bought out the vast majority of ambulatory surgery centers and hospitals throughout the country. This is where I think it's going to go. When they do that, if they can be collaborative and cooperative, they can do a lot to drive some other variables that are affecting the market, not the least of which is private insurance. So if entitlements go away, we're going to have to also reconfigure insurance significantly to make healthcare economically viable And they're going to have to become for-profits because they're going to have to sell stock to raise money to carry out the critical transformations, bring in a high-end agentic technologies to eliminate human error and optimize performance and efficiencies and the work environment and patient safety. And there's a number of technologies out there that are available right now. They just have not been implemented. So agentic med tech companies, I don't have relationships with these companies, but, for example, there's scheduling companies such as LeanTOS and Qventus. Qventus in particular has been used in places like University of Miami and Northwestern to increase the volume in the OR by about 10%. And these are in systems where they're already utilizing the ORs at 80 or 90%. But if you're going to do that, and you're going to stress the system that way, there are other technologies you have to bring in to straighten out your supply chain. You're going to need to straighten out your reusable sterile supply chain. So companies like Ascendco Health, then you have your disposable supply chain. There's a number of companies looking at this. Dorsa comes to mind, Ensight Surgical, ASSI Tech as well. You're going to have better inventory systems that we have now. Currently, it's all hunt and peck when you go into the sterile core in an OR, for example, trying to geolocate stuff within that core. But there are hardware stores like Harbor Freight where they can tell you exactly on a rack where something is within a store that is 5,000 square feet. So there are also inventorying technologies that will be critical to minimize the amount of space and optimize the retrieval of various devices from the sterile core, which not being able to have this dramatically affects your efficiencies. US-based companies are going to do well in this current environment because of tariffs. So if you're manufacturing overseas, it's going to be hard. If your IP is from overseas, it's going to be difficult. You're going to be much better off if you manufacture or you do your agentic technologies in the United States, just based on the tariff economy we are now in under the current administration. I think health education schools that really focus on developing skills as opposed to teaching basic sciences are going to come to the fore. There is certainly going to be a reckoning with universities in the current healthcare environment about what is relevant to teach people. And I would hope with this would come shifts in how we set up the funnel for people to get into healthcare. So to give you an example of how messed up the funnel is right now, in order to get into medical school and graduate from medical school, you're going to have to spend about $231,000 in unforgivable debt. So that leaves a number of people on the sidelines who can't afford this. Furthermore, the way we set up the funnel, you have to go to either a very high-end state university or a private college or university. You have to take the correct courses, do the correct major, do all the correct sort of activities like shadow somebody, do some research, do some volunteer work, et cetera, et cetera. All these are check boxes to get into whatever medical school you're applying to. And then you're going to pay $230,000, $231,000 over 4 years. And in spite of those 4 years, in order to acquire the skills to be a physician, most of those skills will be acquired during the apprenticeship that we call residency. So health education schools that move away from our old model, both in terms of how we recruit students and what we're seeking in terms of recruitment. So I don't think people who get A's in organic chemistry necessarily are the people who are going to get out of bed at 3 in the morning to take care of a sick patient. I don't think that's a very good predictive analytic for that. It just tells you, organic chemistry. Same thing with the MCAT. Not a very good predictive analytic for who's going to be a good physician, for example. But I think that health education schools to start focusing on identifying people that are empathetic and compassionate and have good soft skills and want to learn, develop the critical skills, basic skills for how do you take care of a sick patient. I think they are going to do well in this environment, and because that's what the demand is going to be for in healthcare. We need people who can do that kind of stuff. And then I would say, just from a financial standpoint, institutions that are healthcare organizations, systems that are not as dependent on entitlements such as Medicare, Medicaid, are just financially in a better position than almost everybody else going into this whole mess of the restructuring of healthcare. Losers. I do think with entitlements being cut, patients are going to suffer in the near and probably the long term. So the rationale goes, let's make everybody on Medicaid who's able-bodied passing, a test to show that a work test and make them go to work. And if they don't do that, we're going to kick them off the rolls. But the people really going to get hurt are the people that are going to the hospital, because the hospital now is going to experience half of the Medicaid roll getting purged. The spending goes down. 9% of all the revenue of the national healthcare expenditure goes away with that. Every hospital gets squeezed. Meanwhile, even your insured patients have got to wait in line in the EDs. They got to wait in the queues for surgery. You're going to have less money to pay for labor. You're going to have fewer ORs to run. You're going to have fewer beds to put patients into. You have fewer physicians and physician extenders to see patients in EDs. And everybody, not just poor people, everybody's going to suffer because of this. That doesn't mean we shouldn't fix entitlements. What it means is we shouldn't be doing it suddenly. We need to be more thoughtful and gradual about how we all do this. Hospitals and healthcare systems that cannot become for-profit are going to suffer as well until they get purchased, bought out. I think after everything I've said, that becomes obvious why that is. I think insurance companies are going to actually end up being the losers here, but I think that's a good thing. If you look at healthcare systems in other countries that run well, so the most expensive one in the EU is Germany. In Germany, healthcare is about 11% of the GDP. In the United States, it's about 18% of the GDP. Germans have a much longer life expectancy, well, significantly longer life expectancy than people in the United States. And they pay less for it. And they're the most expensive healthcare program in Europe. But Germany and a bunch of other countries, I think including Japan, all employ what's called the Bismarck model of healthcare. So you have multiple payers that pay in, private, public insurance, but the insurers are only allowed to make a fixed amount of profit every year. They're run like utility companies. So they make money, but they're not making $60 million a day like United Healthcare. They're not allowed to gouge the system. And that keeps things in check. So when I talk about not-for-profits, all these mergers and acquisitions going on and the not-for-profits becoming a bunch of large for-profits, if they can band together and work politically, they could corral the entire insurance industry, or just start their own insurance products and squeeze out all these other companies that don't have their own hospitals. And once that happens, they can start controlling the markets. So I think the insurance companies are going to get restructured as well in order for all this to be fiscally viable. I think there's going to be a reckoning for large medical universities. I think there's been a lot of wonderful things that have been funded by basic science research. The National Institutes of Health, realistically, as a bargain, we pay $40-some billion a year for it. There have been, I think, about 77,000 patents that have come out of research that's been NIH funded since its inception. And it's gotten better at treating a number of diseases. There's certainly a number of cancer trials now going on that are extending people's lives. But the NIH has been the backbone that has supported research at large medical universities. And that budget is now on the chopping block. And one could argue that that's not necessarily a bad thing if they can, I'm not saying that being on a chopping block is a bad thing, but having a forced reckoning for both the NIH and large universities, because, for example, it's estimated there's about 440,000 deaths that occur in this country every year because of medical errors. We probably don't spend enough money trying to understand how we deliver healthcare. we spend a lot more money trying to figure out how do we cure diseases or the war on cancer, all this other stuff, which has had its benefits. But I think in the current environment, medical universities that cannot churn out a high quality product in terms of somebody who you can drop down anywhere and start taking care of patients are going to suffer. And I think their research budgets are going to get cut. And there will be a win-win away of a number of people that were part of this previous iteration of how they ran. So they have, every cataclysmic event like this is a potential opportunity for them to refocus and grow and change. But in the short term, they're going to suffer. Scientific publishers. This is probably esoteric for most people. But when I was in graduate school, you didn't have to pay anything to get something published. That was because all publications, there was no internet, and all publications were in print. And because of that, all the advertising went through the publications. So they had reasonable budgets. There has been a shift that will probably be complete by about 2028, where the vast majority of publishers, and there's only a handful of them, have essentially been pay to play. And it's anywhere from about $1,500 to $5,500 to get a scientific article published. And it seems like you really even can't get a look by them at your research unless you're willing to pay to play that game. Well, with the NIH budget being cut and large medical universities being strained, I don't think that getting published in scientific journals is going to be a priority. So the traditional scientific publishers who have shifted over to this pay-to-play model are going to suffer tremendously. However, that creates opportunities. There are some newer platforms out there that are not necessarily indexed in PubMed, but are peer-reviewed, that are fiscally viable. One of them is JOIE, or JOIE, which is an innovation experimentation journal in orthopedics, which is making very good money. Does have advertisers online, and you can publish in it for free. So there's going to be a reordering in there, but this will have an impact. This reordering of the scientific publishers will have an impact on the scientific literature and how quickly information is getting released out into the public domain to inform our decisions. All right. So that's it for me. You can message me on LinkedIn. I have usually a weekly video blog where I talk about something around healthcare, typically around errors or efficiencies or supply chain, or what I see as the coming collapse of healthcare. Thank you.
Thank you so much, Dr. Nichol. Understanding what is currently happening and where our healthcare system is going is beneficial to not just people in healthcare who work in healthcare. So thank you very much for bringing that to light in this workshop.
You're welcome.
Yeah, absolutely. So thank you for joining us today. And a special thank you to our partners, Ascendco, for making this opportunity possible. If you enjoyed this conversation, don't forget to follow, leave a comment, and share this episode with your colleagues. My name is Monique Boudreau, and I hope you have a great day.